Dr. Amjad, we're ready to get started whenever you are.
Okay, thanks, Jason. Good afternoon, everyone. This is our regular medical cannabis meeting. And I know we have a long agenda, so we'll just get started. But Jason, did you want to do a roll call, please?
Yes, thank you. Next slide, please, Glenba. All right. Dr. Amjad, we know you're here. Dr. Eskew, are you on? Ed Eskew. Colonel Cahill. Dr. Amjad, I know the Colonel is on here, but I believe he's having some audio problems.
Okay.
Joe Deegan.
Here.
Thank you. Dr. Khan. Dr. Khan, are you on the meeting? Dr. Vaglianti.
Here.
Jesse Forbes. Jesse, are you on the meeting? Next slide, please, Glenba. Dr. Barry.
Present.
Sean Hammers.
Present.
Rusty.
Present.
Dr. Antolini.
Present.
Dr. Milton.
Properly.
Present.
Joe Hatton.
Present. Morning.
JJ Burnaby.
Present. Good morning.
Okay, Dr. Amjad, we do have a quorum.
Thanks, Jason. Just want to check if everyone's had time to review the minutes from our last meeting. It was June 16th. And if so, if there's a motion to approve them.
I'll move.
We have a second.
Second.
Thanks. And then Jason, I don't know if there are any public comments for the advisory board.
So we did send out extensive public comment for this meeting. Is there any discussion of those comments from the members?
Yeah, I was just curious as far as feedback from the other members. I read through all of all of the public comments. There were more than 100 pages, and I mean there was a lot of really heavy stories in there, and I just think that that it's important that we acknowledge all the patients that have reached out on behalf of this. And I was just curious as to if I know they were only sent out a couple days ago, but I was curious if all the board members had a chance to read through all of those yet. I do think it's important, and definitely relevant to this conversation today.
Any follow-up discussion to Rusty's comments?
I think the expectation is that, all the board members read all the material that's sent to them prior to the meeting. So Rusty, yeah, I did read through everything, and I can't speak for the rest of the board members, but I know the expectation is that we do that prior to the meeting.
Yes, sir.
Yeah, I will second that too. I think that should be an expectation and responsibility of all of us.
Any further discussion of public comment?
I did read them, and there was quite an amount. I mean, in the hundreds. So appreciate people making their comments.
Any further discussion from the members? Okay, Dr. Amjad, I'd like to move on to the OMC update. I want to take just a second for some public education. It became clear from the public comments that people are still confused between the Office of Medical Cannabis and the Medical Cannabis Advisory Board. These are two different entities. They were both created by the Medical Cannabis Act, but it's important to remember that the two groups may or may not have aligning views. We certainly work cooperatively. OMC provides technical support and administrative support to the advisory board simply because they don't have those resources themselves. But again, I just want to make clear that they are not the same thing. And there is really no reporting structure between the two groups. So that's important to remember. And again, obviously it has been an issue for the public. Something else I wanted to address. After the last meeting in June, there were some social media threats made to one board member. I want to make it clear that the Office of Medical Cannabis, when we become aware of anything like that, we'll forward those incidents to law enforcement and push that they be followed up on to any extent that the law allows. Also for this meeting, I wanted to be clear before we get to the public comment section that no vulgarity or personal attacks on the board members will be allowed. If things start down that road, we will remove your ability to comment. So please keep that in mind.
Jason, before we move on, I did have one question about, there were a lot of public comments that had a lot of information redacted. Can we receive, like, can you send the unedited or unredacted versions to the board, to the members of the board? There have been a lot of people have reached out to me with, some legitimate concerns. And, I do think that we need to address all of it, and I understand the reason for redacting it when you initially sent it out, but I do think it's important for us, if we're going to make the best decisions, and move forward with best practices, that we have all the information. So is that possible? Could you send those out?
Yes, as I mentioned in my email, the vulgarity and personal attacks contained in the public comment were redacted, but if you feel you need an unredacted version to perform your duties as a board member, we will send those out individually.
Thank you very much. Appreciate it.
Thank you. Any other questions? Okay, next slide, please, Glenba. And next slide, please. Okay, just very quickly, because I know we're going to be limited on time here, I wanted to give a brief office update. Something for everyone to keep in mind is this flyer is a new feature on our website. We brought that out this summer. It's updated every Friday with the metrics from the office. Real quickly, we've received over 14,000 applications. At this point, we've approved almost 13,000 medical cannabis patients. 9 out of 10 growers are operational. We have 30 operational dispensaries now and 5 operational processors. We've sold almost 1,450 pounds of medical cannabis, almost 200,000 individual items, and there has been $11,675,000 in revenue from medical cannabis sales to date. Any questions about the progress of the Office of Medical Cannabis and program implementation? Okay, next slide, please, Glenba. All right, now we're going to turn it over to Dr. Berry, Chair of the Health and Medical Work Group, so he can summarize his previous meeting from August 16th. Next slide, please. Dr. Berry, go ahead whenever you're ready.
Yeah, thank you, Jason. So the subgroup met on August 16th. We had a quorum of our members. Fortunately, there were a number of the physician and other medical providers who were actually able to make that meeting this time. And then we also had a presentation by Dr. Libby Stout, who is a physician working in Colorado, an addiction psychiatrist. And she was able to present the actual evidence about THC potency. So we were able to review that in a number of her slides. And the conclusion that was drawn from that presentation was that the medical evidence to date really has only supported the possibility of using THC potencies of 10% or less to help with any medical condition. And at the same time, there has been a preponderance of evidence associating higher THC content with a number of public health concerns, such as suicide, psychosis, addiction, depression, anxiety, these sort of things. And after we discussed and reviewed this, the recommendation was unanimous in that we attempt to look at capping the THC content of dispensed products to 10% or less. And so that was the recommendation that we wanted to bring before the board.
Is there any discussion of Dr. Berry's proposed recommendation number 1?
Yeah, I've got thoughts. I just, again, we've had this discussion once before. This recommendation was proposed and it was, the board voted it down. And I'm really frustrated because I watched and I watched the presentation. I think it's important to note that the data that was used in those slides was from 2007. It has been debunked a number of times by multiple research institutions. And when we're talking about efficacy of this medicine, one of the things that frustrates me, it frustrated me the whole conversation during the home grow conversation, and the same talking points were brought up during this. Patients are automatically looked at, again, as criminals. Dr. Stout said in an interview with West Virginia Public Broadcasting that was released yesterday that patients seeking products with more than 10% THC are just looking to get high. That's a slap in the face to medical cannabis patients. As somebody who has used this product or used these products for years to deal with neuropathy and the issues that were permanently, I was left to permanently deal with after aggressive chemotherapy. All you're doing with a 10% THC cap, you're going to force patients right back to the illegal market. You're going to potentially kill the industry completely. And when you talk about issues with addiction, I mean, just read through the public comments. There's more than 120 pages of public comments with folks dealing with all sorts of issues, from cancer and leukemia, from ALS. There's HIV patients in there, and they all, one of the recurring themes is they have been able to get off of pharmaceuticals, a number of pharmaceuticals, with THC, with cannabis products. And if we put a 10% cap on THC, you're going to put them right back into that cycle of pharmaceutical addiction. This is absolutely the wrong way to go. As doctors, you swear an oath to do no harm. A 10% THC cap is doing a lot of harm if this should pass. I think it's the wrong way to go. I think for sure, if this is going to be something that, obviously it passed through the work group with a unanimous vote. If we're going to look at this as a serious recommendation, then we need to bring folks in here who are doing FDA research with cannabis, and get them to weigh in on this issue. I don't think that we should be pushing THC caps based on the opinion of just a handful of folks in opposition to this issue. We have people, we have the ability to bring in people like Dr. Russo, Dr. Abrams, Dr. Doblin, Dr. Miller, Dr. Grant. All of these people are doing FDA research right now on this plant. Those are the people that we need to be bringing in to weigh in on this. I don't think trying to vote on it today and push this through the legislature is the right way to go. And I do believe that before a vote is taken, we need to hear from industry. We need to hear from patients. when I spoke with a cancer patient the other day who was literally dying right now, and has had no relief, got a medical cannabis card, bought some flour. The flour was above 10% and it did nothing, didn't do anything for their nausea, didn't do anything for their neuropathy. And then the dispensary started to carry concentrates, which were much higher in THC content. And those concentrates have been able to provide this person with relief. She was in tears talking about how if this is passed and they implement this 10% cap on the program, she would rather die. This was a real patient testimony. And I know that hearing from patients, we always talk about how it's anecdotal. To me, it's not. Lived experience is the most important part of this discussion. And I think that it's also important to note that, at least, unless I've misread something on the list of certified physicians, none of the physicians on this board have gone through the continuing education courses and are certified to recommend or to certify patients to participate in this medical cannabis program. So we have doctors making decisions that are not educated on what's going on with the program. They're not educated on the products available for patients, and they're not listening to the patients that are telling them, hey, this is what works for me. That's a problem. So my personal opinion is we should absolutely not be voting on this until we have proper information, and we're not going off of information presented from a study done in 2007. So that's just where I'm at on it. I'm hoping that the public comment period today, I hope that there's some people from industry and patients who are living this in real time will share their stories, and we'll do what we can do. But I do think that putting a 10% THC cap is absolutely moving in the wrong direction, and it's going to kill this program. So that's my thoughts.
I've got a question. I don't know if it's all right to jump in, or if you wanted, somebody wants to address what Rusty said. I've got a couple of questions about the recommendation.
Go ahead, Justin.
Thank you. So one, I wondered whether at the work group or present today, has anyone from industry weighed in on this? Because we got into this previously, and this program is still in its infancy and is still getting implemented and coming out and being in a position where industry can be viable enough to support the patient needs that the legislature and governor already decided the patients needed. So I've got concerns, if we haven't heard from industry, as to what this would mean for them. Because if we don't have a viable economic program here, I don't know whether is this going to cost a considerable more money for industry to try to redo products that are already on shelves, or how is that going to work? The other issue that, I just doing a little bit of research myself on this is that the last I saw, only one other state in the union had adopted caps, unless that's changed, and that was Vermont, who I think has a 30% for flour and 60% for synthetics. And I may be off on those numbers. If I am, I'm sure somebody here can correct me. I wondered whether any other states have adopted any cap similar to this, because one of the mantras I've had since, and I've been on this board since it started, was we shouldn't be reinventing the wheel. If this stuff is working across the country and has been for a very long time in other states that we can look to, it makes sense to me that we follow those models, as opposed to trying to go out with a small population and be the first people out trying to do this. The other question I have sort of touches on something Rusty said, but not exactly. Are any of the certified physicians that are actually certifying patients in West Virginia, have any of them raised concerns about the potency? And if so, could we get some of them to come speak to our group? Maybe if not. I think it would be helpful to hear from the people on the ground. We can sit in this tower and dictate advisory opinions. Of course, ultimately this is all for the legislature, but I'd like to know what the doctors that are treating patients are seeing. And so, those are a few of the questions I have. Mainly, what does industry say? Because I really hesitate to start doing something that's going to affect this overall from an industry perspective, and maybe cost not only jobs, but also the ability to help patients. And then what are the physicians on the ground that are certifying patients seeing, and what do other states do? So those are my questions. If anyone, I don't know if that's something Jason, the office would have information on, or perhaps the office could collect information on that and present it to us at a future meeting. Or if that's something, Dr. Berry, that you all talked about in your work group. I wasn't able to watch that work group meeting.
Jesse, I can take a stab at your questions, then perhaps turn it over to Dr. Berry. As far as industry goes, there were no industry representatives during that work group meeting. However, there were industry comments that were included with the public comment that was sent out to the members. Also, I do want to point out there are several members of industry on the meeting today that may make themselves available for comment. As far as other states limiting THC percentages, I do believe you're right. It's a very rare instance for states to do that. Some states, such as Ohio and I believe Florida, incorporate THC percentage into their patient purchase allotments in various formulas. We chose not to go that route because it does complicate the process immensely. Dr. Berry, did you have anything to add to that?
Yeah, a couple of things. One about the states. So Dr. Stout I believe she's on, so she could talk more about Colorado, but I know that the legislators actually looked at that and have, or at least are in process of trying to put some limits to that. And I also know that in Florida last week, there was an emergency order to do just that, to put a limit and a cap on the daily doses of THC.
Do you know what the Florida limits were, or the proposal? I guess
I just pulled it up so I could send it to the board if the board wants it.
Yeah, I just kind of wondered what Florida is looking at in terms of percentages.
Yeah, for daily. So they've got it in grams, but we could send that to you, or I can send it to you. The other thing I would say, to Rusty's point, I totally agree that the physician's duty is to do no harm. And that was the purpose, and that's what I see is the purpose of the health and medical work group. So I guess, there was no industry involved, though they were welcome to participate, but really it came down to what are the potential health risks and the potential consequences. And certainly reviewing through the public comments, try to address what is my motivation, because my motivation for why I am trying to do this and other things certainly has been questioned. And to give you some background, I moved here 20 years ago, exactly 20 years ago this year. And I moved here right out of medical school because I wanted to really practice addiction psychiatry. And it just so happened that when I moved here, we were just on the cusp of our addiction pain pill epidemic. And so started seeing folks come in through the emergency department into our psychiatric facilities who were suffering immensely from pain pill problems. And at the same time, of course, we had this huge industry that had been touting the safety of pain pills, high potency opioids, and totally minimizing any of the risks. And so when my colleagues and I in the addiction community started making people aware of what we were seeing the huge overdoses, seeing the addiction that was occurring, seeing the suicide and major depressive problems that were occurring, we were told that we were blowing this out of proportion, that we were opioid-phobic, that we were insensitive to people who were experiencing pain. And even back then, the industry did a pretty impressive job of getting even patients who were experiencing pain to come, scores of patients to give their anecdotal stories and personal experiences of how these pain pills, these high dose pain pills, was really effective for them, and it wasn't causing any problems. And then what we know, what happened over the years to come. And it took a leg, it took a time. So you know that the pharmaceutical industry, especially Purdue is one of the major ones, did concerted advertising and marketing and really try to get the public to believe that there were no harms associated with opioids, high dose opioids, and it didn't cause addiction if it was treated all manner of pain. And so that, of course, was proved to be not true. And there was a leg. So that was in the mid 90s. I started seeing people with these problems in the early 2000s, trying to make people aware of it. And then it wasn't until the mid to late 2000s that then we started seeing the public health crisis that we have today. So my motivation behind what we are trying to do is to try to actually put some safety guardrails in place to make sure we are not repeating many of the same problems that we repeated with the opioid pain pill crisis. And now you see a number of states that are trying to retrofit some of these guardrails into the policies and the procedures that already existed. We have an opportunity, as this is starting in the beginning, to try to put those guardrails in place right now. And so that's the motivation behind this, and that's what we're trying to do.
I mean, I appreciate those comments, and I'm not trying to question your motivation. But let's put it down like this, right? I spoke with a patient at 7:30 this morning that had shoulder surgery yesterday, had pins put in her shoulder. She left the hospital with 30 Oxycontins. That was the prescription. She would rather use medical cannabis to heal up and recover from this surgery. What do you think would be more detrimental to her health and more likely for her to become addicted, if she healed with those 30 Oxycontins or if she healed with medical cannabis? Because, you know, there's a lot of fear in these conversations, and we're talking about all these how the sky is going to fall. California has been doing medical cannabis since 1996. You know, we're almost 30 years into this experiment in California. You know what we're not seeing? We're not seeing people overdose and die from medical cannabis or cannabis, period. It doesn't matter what the concentrate is. It doesn't matter what the product is. No human being in the history of time has ever passed away from a THC overdose, ever. But we're watching people die every single day from opioids. And if we put a THC cap on these products, folks who need these higher doses, what are their options? They either go back to pharmaceuticals, which we know can addict them and can kill them, or they're going to go right back to an illegal market and then buy who knows what off the street. You know, that's where I'm at. So if, as a medical professional, if you were talking with a patient today, if she called you for advice and she said, hey, I just had this massive surgery, had to have pins put into my shoulder. Here are my two options for healing. I can either use medical cannabis products, or I can take these 30 Oxycontins. Which one, what, of your opinion, which route would be safer?
Yeah, so you're absolutely right that we don't see overdose deaths with THC or cannabis. That's absolutely right. But your question is really a false dichotomy. It's not either taking high dose oxycodone or high dose THC. That's not the solutions that are available. There's a lot of ways to be able to treat even post-surgical pain, and I could let some of the pain doctors discuss that, but there are a lot of other ways to do that. But regarding the harms associated with THC, it's not just overdose. So we are dealing with people who are coming into our hospital who are immensely psychotic, related directly to the THC that they are using. We are dealing with people in our hospital who are suicidal and severely depressed because of the THC that they are consuming. And so where do we draw the line? How do we figure out what are the right barriers to be able to mitigate that risk between what is happening even now, and how do we do that then and provide even a product that could be safe to help with some medical conditions?
Well, but by that rationale, if you took a graph from, and again, I'm going back to California because they've been doing this for 30 years. But if you take the graph from when medical cannabis was implemented and looked at it over the following 30 years, and then you take a graph of reported cases and diagnosed cases of psychosis, you would expect, from what you're saying, you would expect the rates of psychosis to be rising with the rates of cannabis use. And that's not what we see. That's not
No,
what we see.
I will correct you there, Rusty. It is absolutely what we're seeing, not only here, but also across the world. So,
Okay,
for
so
instance,
I need to see some peer-reviewed studies on that. You know,
yeah, and
a study
let-
from
let's-
2007 is not cutting it.
I will happily provide the studies that are out there. And I agree. I think if we're going to make medical decisions, then the standard should be the peer-reviewed studies that are well equipped to help answer the questions that we're doing. So let us use that as the standard for the decisions that we are making.
I'd ask, has anyone heard from the certifying physicians as to whether they have concerns? Because my understanding is they're the ones that are actually treating these patients and then certifying that they could benefit from using the product. So I'm just wondering, have we heard either at your work group, Dr. Berry, or elsewhere from the certifying physicians as to what they're seeing and if they have a concern about the THC levels?
Yeah, I have not heard personally from certifying physicians, though they are welcome to reach out to our group. But I guess, Jesse, in some ways, I don't know, and I don't want to disparage anybody or anything like that. But to me, it's not so much what am I hearing from those who are certifying, because also I don't know what are they actually doing as far as following up and monitoring. And we have no real again, guardrails or even guidelines about what that means. And so even, back in the mid 2000s, okay, I wouldn't necessarily reach out, though I would often do that to somebody who is prescribing OxyContin to find out what their experience is with their patients, because they might not even be seeing the problems. It's those of us who are seeing the problems are the ones in the addiction and the psychiatric world.
Can I ask you a question on that? Because you mentioned the psychiatric reactions that you're seeing in your hospital. Are those patients with medical cannabis cards that have been issued by West Virginia?
Some, yes. And other physicians who have reached out to me since have also expressed the concerns of people coming into the hospital, psychiatric facilities with medical cannabis cards. And that gets to the second recommendation. They want to be able to have a way to reach out to the certifier so they could discuss what is happening. So the answer to that question is yes.
Yeah, no, and I understand that completely. And I think we got to get to that second recommendation. But with the first one, I'm just wondering, do we have any data, any numbers of, because I think, we're at what, 13, 14,000 cards issued. I'm just wondering how many numbers of those have been hospitalized with a psychiatric reaction.
I think that
I want to be clear. I'm not trying to dissuade what your group's doing. I just want to know we have the right information to look at, because I'm looking at the Florida rule, I guess, that just got enacted, and I just pulled it up online while we're sitting here. It doesn't seem to have a THC cap. It looks to me like it has a 70-day limit for non-smokable marijuana of 24,000 milligrams of THC. And then for flower, there's no THC limit or THC concentration limit. There's a total 2.5 ounce limit during a 35-day period. So I understand the mission and the idea that we need to look at, should the legislature put guardrails on this. I'm just wondering, what work are we doing to say what the correct guardrails are and how we arrive at what those are? And I think we can look at some other states. And Rusty mentions California. Our bill was modeled off of Pennsylvania. I don't know what, I haven't heard whether they've enacted any of this, but I just like some more information. I kind of wonder how we get to the 10% without knowing some of these other things.
Yeah, and I think that is fair, and I think that's worth thinking through. And basically the 10% was based on the medical literature that has actually looked at this.
Folks, I just want to make sure that the entire board has a chance to put forth any perspectives they have. Does any other members want to comment on this debate?
Yeah, I'd just like to say, Jason and others, that there really are no recommendations for follow-up, and part of the allure of this is, you may or may not see the patient one time and certify them, and there are many advertisements out there of online certifications via telemedicine or telephone visits. So we really don't know what the quality is of the evaluation that's done before the certification actually occurs.
Well, to that, I do think, again, it's not like doctors in West Virginia can just recommend cannabis to whoever they think can benefit. Although I personally believe that's the way this program should run. We should allow doctors to perform medicine. All they can do, even in these telehealth conversations, is certify that you have one of the conditions. So, if you're presenting proof from your doctor or from a hospital or whatever the case may be that you do have one of those conditions, that's all they're able to do. So as far as like the telehealth appointments and all that, I don't know how there could be any kind of issue with it, but they're not really performing, they're not practicing medicine. They're just certifying that you have a condition.
Yeah, so I understand that. And that's a great point. So then they would have no knowledge then of what the downstream benefits or harms were. And that's a problem.
I do want to point out that Rusty is right. The decision that folks with these particular conditions have access to medical cannabis was made by the legislature. The physician's role is only to certify that they have that particular disease. But as part of that certification process, there does have to be an ongoing relationship with that certifying physician. We've defined that as at least an annual visit. If the patient does not follow through with a certifying physician, at least annually, OMC will revoke their card.
And that's another issue with, these annual recertifications and these annual appointments. Patients are coming out of pocket because insurance doesn't cover anything relating to medical cannabis. They're coming out of pocket $100 to $200 a year to keep these cards. And, a lot of folks, again, I know I've mentioned it in meetings before, but I've actually met people at dispensary openings who bought their cards. They were at the dispensary opening just so they could see it all go down, but they couldn't afford to walk in and buy medicine. When people are buying these concentrates, at least from the patients that I'm talking to, again, that's why I take so much issue with when I hear comments like was made at the work group meeting that's, well, anything over 10%, people are just buying to get high. That is looking at this issue like patients are criminals and patients are automatically getting into this for recreational reasons. And that's not the case. If you talk to a cancer patient, I don't know if anybody else on this call has gone through aggressive cancer and all that, but it financially devastated me. I went from running a successful business, I was fine with money, no issues whatsoever, to destitution and homelessness in 3 months because cancer is so expensive. And when patients buy these waxes and these concentrates, while they may only be buying a gram, that gram is going to last some patients 2 to 3 weeks because you take such a small amount of it. You get the relief that you need, and then that's it. It's not like we've got patients who are buying these products just to sit around and get stoned all day. Is that happening somewhere? Probably. Just like people are going into the doctor's office and getting opioids and sitting home and abusing those. Is that going to happen? I'm sure it's going to happen, but is that the norm? Absolutely not. Absolutely not. And a 10% THC cap is going to put people who are already in, pretty bad financial dire straits. It's going to put them in a situation where they're having to buy more product just to get the desired effect or to get the relief that they're looking for. So that's another component to this is, I know that when we're talking about efficacy of medicine and all that, cost really shouldn't be a main driver in the conversation. But when you're in the most economically depressed state in the country, it has to be. It absolutely has to be. So I think that's another thing we need to look at.
And may I speak for a second? This cap, I'm trying to figure out who we're actually trying to protect, because my assumption is, these diagnoses are being certified by a physician. Physicians can't actually dose this medication. The patients are titrating. And so this is really an inexact science to begin with, right? And so I mean, who, if we're trying to stop responsible people who are taking their medication from taking too much and inducing psychosis, who's to stop them from just hoarding their medication and then having a good old time, you know, infrequently? You know, that we're not really stopping anything by imposing a cap if people are going to abuse this medication just like any other medication that's prescribed. And so in that sense, you know, considering that, I feel like, you know, imposing a 10% cap at this point in the game, especially in light of what economic damage it may do to the people who are trying to get lifted up in this industry, I think it's arbitrary and probably a little too limiting at this point. If I were going to support a cap, it would probably be more in line with what other states are doing and not so low at the very least.
Yeah, I believe Ohio's is 35%, I believe.
Would any other board members like to enter the discussion?
This is Joe. Can you give us some examples of some of the current THC levels in the products that are being utilized?
Yep. So, Joe, I can chime in on that. Flower is going to range anywhere from low teens to mid 20s, low 30s at the absolute highest. Concentrates can way up there to 90%. It just depends on the processes used to make those products. So there is a wide range of THC percentages available to patients currently in the state.
And there's no interaction between that THC level and the type of ailment that they're trying to be treated for. Is that correct?
Not from a regulatory perspective. They're limited to purchasing an amount of THC. We don't dictate the percentage of that amount made up by each product purchased. So we're just going by the total amount purchased.
And again, just from an anecdotal standpoint, you know, I know it doesn't matter. But when I was going through chemotherapy, they blew out my right arm and continued to run chemo for 5 hours that day and burn up my right arm, right? Like it's excruciating. It never stops. The neuropathy and the issues I deal with never stop. And I have gone to multiple dispensaries and I bought multiple products and I've tried. I've been looking for relief for this issue since 2012 when it happened. So far, the only medical cannabis product that I have been able to get any kind of relief whatsoever was 60% THC. So, you know, 10% THC cap's going to do nothing for people like me whatsoever. I could spend all the money in the world and I'm still not going to get any relief. I basically have to be consuming that product all day long to even get to a point where it touches it. So, you know, I know that a lot of people, when they hear these THC contents or these THC amounts of 60 and 80% and all that, they automatically clutch the pearls and get scared. For a patient that needs this medicine, again, 1 gram of a 60% THC product will last me weeks and weeks because you don't need very much at all. If you're using this medically, you know, patients, again, I can't stress enough, we have to treat patients like patients and not criminals. These cats are not going into the dispensary to buy concentrates to go home and get stoned. They're trying to find relief and trying to get to a point where they can function and live a normal life. So, you know, some of these higher THC concentrated products are absolutely crucial for a lot of people dealing with a lot of things. It's nothing to be scared of.
I don't know, Jason, how we're handling the recommendations, if we're going to move to recommendation 2 and then take them up, but I know we're kind of running into a lot of, you know, it can be a time crunch soon. I've got a suggestion that with respect to recommendation number 1, that the board not take action today, either way, that we get more data. And I don't know whether that's something that Dr. Berry would want to do through his work group, or we bring that to the full board meeting next time. I'd like to know specifically what Florida and Ohio have enacted because I've not seen those in any detail. I looked at Florida while we're sitting here. Personally, I'd like to hear from at least some certified physicians that are out there as to what their, sounds like there's some question as to what their process is. And I'd like to hear from the industry folks as to what it would mean if we put a cap like this in place. But I'd really like to know, the data from the other states, what they're seeing, so we can hopefully model off of something that we think makes sense if putting some type of guardrails is something that the board wants to do or recommend. Ultimately, it's the legislature that would do it. But that's my suggestion is that we get some more data. I'd also like to have data on how many, if it's possible, how many medical cannabis card holders have been treated for psychiatric issues. And I know that may be difficult under HIPAA. I'm not sure. Maybe recommendation number 2 would help us with that. But those are just some concerns and thoughts I have. And my suggestion, I can make it a motion at the appropriate time, would be to table any action on recommendation number 1 and get more data.
So Jesse, you're right. Time is a major concern here. It's totally up to the board's prerogative if they want to take action on these recommendations. However, I would recommend if the board does want to take a vote to pass either recommendation, that it allow public comment before the vote takes place. That has been an ongoing concern expressed by members of the public, and we've implemented that in any work group decisions that have taken place in the recent past.
I'm inclined to agree with Jesse. Again, when we talked about home grow, it was kicked down the road for a year and a half. We need more people, more experts. I brought in people from the regulatory side of things that have worked in multiple states, people from the policy side of things, and we need more information. On a recommendation like this, home grow would have expanded this program to a lot of patients that truly need this medicine. This recommendation has the potential to kill the program completely and put a lot of people right back into the illegal market. So if we're going to, I think we need to approach it with the same intent that we did home grow. We need to open this up, bring in people, experts from out of state, experts that have been dealing with this, and we need to hear it out. I do not think we're ready today to take a vote on it. So Jesse, if you were willing, if you would make that motion, I would be more than happy to second it.
Well, and I know there was a talk about public comment, but it seems to me if we wouldn't be taking action on it, I think I'd go ahead and move unless anyone feels differently. I'd make a motion now to table action on recommendation number 1 to get more data, either to be presented through the work group or to the full board along the lines of what I said a few minutes ago.
I would be supportive of that.
So when would that action take effect? Next meeting, we would come back and discuss this?
I think we have to discuss it as long as it takes. And another thing I would ask for the members of the board that aren't on the health and medical subcommittee, when the meeting notice goes out, if you could send that to all of us so we could, at least tune in and listen to the discussion, that would be super helpful. I watch the Secretary of State's website, the meeting notice section of that site pretty frequently, and try to keep patients and people updated as far as what we're doing on the board. And I missed the last one. I didn't know that the health and medical work group had met until the day after. And so if we could all be notified of when the subcommittees are meeting, I think that would be helpful as well.
Yeah, we can do that from the OMC side. So Jesse, are you making an official motion to table recommendation number 1?
I am. I'm making a motion to table recommendation number 1, and that we could have further discussion at our next full board meeting. And of course, I'm not on the health and medical work group, so if they want to take it up in the interim, I think it would be beneficial. But of course, that's up to Dr. Berry.
All right.
Would it be in order or more appropriate to make a substitute motion, Jesse or Jason, as far as to continue to have this discussion, with these parameters, meaning bringing in more experts, presentations, so that this could be more thoroughly vetted and we can really examine the issue. You see what I'm asking?
Yeah, no, I think that's what I had in mind. And to the extent that I wasn't clear about it, I appreciate it. Yes, I'd like to have more information, experts nationally, the information locally from the certifying physicians and industry, and the data along the lines that we talked about really the last half hour. I think that information will be helpful because ultimately, I mean, our role is to try to do this type of investigation work so that when we make recommendations to the legislature, it's based on things that they may not have the time or ability to focus on. So I think it's going to be helpful ultimately to the legislature if they can see what we looked at if we ultimately make a recommendation.
Yeah, got it.
Yes.
Agreed.
Okay, so
to that effect.
So to recap, I think we have a motion here to table recommendation number 1 for now, but ensure continued discussion and exploration of that recommendation. Is there a second?
Second.
So-
I'll second.
So
All right.
technicality, Jason, you need, if you're going to go and bring that back up again, it needs to not just be a table, it needs to be a table with the expectation that next board meeting, that is a topic of discussion.
Yeah, that's what I was getting at too.
Yeah,
Otherwise, it's tabled indefinitely.
Yep.
It can never be brought back.
yeah, and I
Yeah.
would support tabling it indefinitely. You
And,
know,
and that's not my intent. I'd ask that we take this issue up at the next meeting with more information to be presented.
so can't we refer it back to the health committee for more information, put that wording in the motion?
Yes, I'd agree with that, and I'd amend the motion to that effect.
Okay.
Good
I'll
catch,
second that.
gentlemen. I thought we may be able to sneak that table by you. Good catch.
All right. So we have a second motion. Is there anyone, just to simplify this, anyone that would vote nay to the proposed motion? All right. So we will send this back to Health and Medical and also have it on the agenda for the next main meeting. That's recommendation number 1. Moving on to recommendation number 2. Dr. Berry, do you want to explain that?
Yeah, that came out within the discussion of our last group, work group, but basically kind of arose because we know it's going to take a while, if it happens at all, that physicians will be able to monitor this on the prescription drug monitoring program the way we do other controlled substances that are FDA regulated. And the concern that we've had from providers where they are seeing people who do have medical marijuana cards who are having severe problems and want to be able to communicate such with a certifier so that they could work on solutions to help that. And so the recommendation was to provide a timely process to allow medical providers in West Virginia have access to the available list of certified patients.
Okay. So Dr. Berry, as promised, I did speak with our legal counsel about this. There's no way that we can just send out a list of patients to all providers in the state. As you mentioned, last year, the board did make a recommendation to add medical cannabis to the prescription drug monitoring program that's administered through the Board of Pharmacy. For our clarification, are you recommending that
10%.
that same board recommendation go back to the legislature again, or are you recommending a legislative change that would allow us simply to provide a list of patients to providers in the state?
So
Hey,
go
Jason,
ahead.
before he answers that, I just want to, my charge out of the meeting was to follow up with the Board of Pharmacy and get some information that may be helpful to this recommendation and how we're going to move forward. What I know is that the Board of Pharmacy would be able to work with the Medical Cannabis Board to come up with stipulations as to what would be reported to the Controlled Substance Monitoring Program. If you want to be very specific and you want to classify each of those products a certain way, that would become more difficult. But if you strictly wanted to provide to the monitoring board the location, the patient's name, and the amount of grams or something along that, something that's something that's loosely categorized, that is not a difficult thing to do. Now, as far as the legislature and adding that, I think the Medical Cannabis Board has the ability to do that. So I just wanted to make sure that was clear. So having a list of certified patients, through HIPAA, that I understand that may be an issue, but if we can work down the path of just reporting to the monitoring program so physicians are aware that patients are on this therapy so that they know how to incorporate that into all the rest of the medical solutions that they're providing, that may really get us where we need to be.
So JJ, to further clarify, does the Board of Pharmacy still contend that legislative action is needed to allow that limited reporting?
Well, I asked that exact question, and I don't think, from what they said, they don't think that there's legislative action on the Board of Pharmacy's part, but how do we get things added to that controlled substance monitoring program, whether it's a drug of concern or whether it's a true controlled substance? That question is, we can bring something to the legislature, the Board of Pharmacy, that says we want, for example, gabapentin, when it wasn't controlled, we want gabapentin to be on that controlled substance monitoring program. I don't think the Board of Pharmacy, at least when I talked to Mike Goff, we're not the only ones that have that ability. So he thought that possibly the Medical Cannabis Board had the ability to say, we would like this to be part of the controlled substance monitoring program, and they can work with the Board of Pharmacy to format that with the IT guys so that they could report it. I know that's not a real clear answer to your question, but that's kind of all the information I got.
All right, thank you.
Just thinking this through from a legal standpoint, I know the board made the recommendation last year to the legislature. I mean, we're an advisory board, so I don't think we can actually take any action to do any of this. I have some concern if legal counsel has looked at this and thought that a legislative action was needed, that maybe legal counsel for DHHR should talk to the legal counsel for the Board of Pharmacy, and we could get a report as to what this group could do to try to effectuate what the needs are or the apparent needs are. Because Jason, correct me if I'm wrong, but we essentially made that motion last year to the legislature, and then they've not changed the law, right?
I would say that's accurate. It does sound like that's basically the recommendation was made last year. At that time, we were advised that legislative action would be needed to allow medical cannabis to be added to that system. Maybe that's changed. We can certainly explore that. But as of right now, it's my understanding that legislative action would still be needed.
So independent of that, I think as part of the advisory board in our work group, we would make the recommendation that physicians should be aware that their patients are on that medical cannabis therapy. Now, how that's done legally, we can vet that out, but I think it's really clear our work group is under the impression, I don't want to speak for everybody, so correct me if I'm wrong, we're under the impression that physicians who see patients in West Virginia should be aware of every therapy that they're on, including medical cannabis. So we want to try to figure out a way to get that done. A master list given to every physician probably doesn't sound like the best way to go, but reporting it to the monitoring program where every physician by law has to have access to would give them that picture of the therapies that their patients were on.
Yeah, I would say that captures the spirit of the discussion behind that recommendation and what we're trying to accomplish.
So if that's the thought, then it sounds to me like we need the lawyers for the two agencies to talk, so that if this board makes a specific recommendation to the legislature, that the language is such that it's not going to violate any potential HIPAA laws or anything that's out there, and that it's tailored so the legislature could take it up and know that it's been vetted by legal counsel for both the Board of Pharmacy and for DHHR, because those are the two agencies that are going to be sharing the patient information with everyone.
And I can certainly facilitate that discussion between the two agencies.
Is that a discussion? Would that happen independently? Like, would the DHHR or the OMC set that up? Because it's my understanding, just from working on the policy side of this stuff with our legislature for the last decade. So we've already made the recommendation to add cannabis to the CSAP program, right? Like that recommendation's already passed the board and it's already pushed to them. So if they take this up, if they take the issue up and it draft a bill and there's legislation moving, wouldn't those conversations happen, during the committee process and all that? Or is it something that you guys recommend we preemptively do through the board? Like, I'm just not sure as far as legislative action goes. I'm not sure how that would work out. What would be the best way to go about it?
So Rusty, at least from my perspective at the moment, it sounds like we're not super clear that legislative action is still necessary to allow this reporting. I think it probably is, but we're not 100% on that. So we could definitely explore it. And, even if legislative action is needed to allow this reporting, I think it would be important that we've done that background homework on the situation between the two agencies. So I think either way, those discussions should happen before the session.
Gotcha. Thanks for a clarification.
Yeah, I would also say, in addition to making at least, again, what the spirit is of what the physicians are concerned about is that we are able to identify the person who has the physician who has certified. So if there are issues, we want to be able to contact the certifier so that we can discuss those issues and really try to help the patient.
Any further discussion of recommendation number 2? All right. So to recap, I think where we're at this point is it's been recommended that DHHR facilitate discussion between ourselves and the Board of Pharmacy to determine whether or not legislative action is still needed to allow medical cannabis to be added to CSAP. Dr. Berry added to that he wants to ensure that information on the certifying physician is available to a prescribing physician. Do I have that right? Does anybody want to add anything else to it?
That's right from my standpoint.
All right. Perhaps, because we do have a proposed recommendation here, perhaps someone would like to make a motion that we take that action and then bring the recommendation back up to the board with more information similar to what we did with number 1.
So moved.
I'll second.
All right. Again, just to simplify, any nays on that action? Okay. So OMC, on behalf of DHHR, will facilitate that action and bring more information back to the board. All right, Dr. Berry, those were both your recommendations. Do you have any more information from the Health and Medical Work Group?
I don't. Thank you very much.
Okay. Glenba, next slide, please. Okay. We took no action as far as approval on either recommendation. The plan was, if we got to that point, to have public comment before any sort of approval vote took place. It wasn't needed. So now we're at the point to accept public comment. Real quick, before we start down this road, does any other board members have any discussion they want to have before we start live public comment?
No, I just have a comment to what you brought up earlier. As the person on the board responsible for doing the patient advocacy work, I always put out notifications on social media and always try to let patients know what we're doing. And I try to encourage people to engage, to get involved in this conversation. But to what Jason said earlier, these personal attacks and bringing people's family and all that stuff into like, that's absolutely unacceptable. And I'm asking folks that if you're going to participate in this discussion, please be respectful with your comments. I've spent a decade working with the legislature and trying to create a medical cannabis program here that we can all be proud of. And regardless of the fact that we're patients and there are folks who really need this medicine, there's a stigma that is still there. And anytime patients reach out, and trust me, I understand you're frustrated. I'm frustrated too. I've been watching this whole process roll out with a front row seat from day one. And it is very frustrating to see some of the things, but if you're going to engage in the public comment period, please keep your remarks respectful, because all of the threats and all of the antagonistic tone that gets thrown through, that is just furthering the stigma, and it's making it harder on patients to be heard. So, I just wanted to throw that out there. And to Joe, those messages that board members received, it was unacceptable. And, as patients, we got to do better.
Yeah, thank you, Rusty. And again, just to recap what I said earlier, any vulgarity, any personal attacks during the public comment, we do have the ability to remove your ability to comment, and we will certainly do so. So, Crystal, if you'd like to turn on the chat feature, please, as we usually do.
One question, Jason.
Oh, yeah, sure, Joe.
Other board members here. Did any of the other work groups meet?
So Jesse's work group, policy and program did not meet during this interim between main meetings.
Okay, so there's no other business before the board then?
Correct.
Thank you.
All right. So, folks, again, if you wish to comment, please use the chat feature. Enter your name. We'll call on you one by one. You'll have 90 seconds to comment. And enter your name if you wish to do so. So first, we have Dr. Stout.
Thank you very much. I just have two comments. One, number one, Rusty did misrepresent my presentation to the board. I would love to send that to everyone. I don't know what he was talking about, 2007. All of the research I was presenting was from 2015 to 2022. So it's all very relevant and recent literature. My other comment is I love the idea of getting recommending physicians involved in the discussion. I think that would be an excellent idea, and I would love to hear from them.
Thank you, Dr. Stout. A little bit of follow-up to that. Your presentation was provided directly to the board members. Next up, we have Tina Yates.
Hi, thank you. So I'm here on behalf of my spouse. He's a Marine Corps veteran. He's 45 years old. Somebody's mic is on and it's echoing really bad.
Kim Magruder, please mute yourself, please. Thank you.
Thank you. Okay, so he can't be here today because he has severe arthritis in his neck from his service in the Marine Corps. He occasionally has to receive injections in his spine and between the C and T spine, and those put him down bedridden for the entire day. So since beginning medical cannabis, we were at the beginning. So he was 44 when he started. He was able to, he had to get an injection at that time about once every 3 months. They kept getting closer and closer. And towards the end of those injection periods, he would be in a great deal of pain, constant pain every day. And so, even a sneeze would be excruciating for him. And since beginning medical cannabis, his last injection, he was able to go 9 months without it. He's hoping to get up to a year because there are potential side effects, including death to these procedures. And so with limited time, the only other thing I would like to point out is that if 120 people submitted comments, like any other, political type situation, I would guess there was at least 1,000 in the same boat who didn't, at least 1,000 per person who didn't submit comments. And
Ms. Yates, I need you to finish up, please.
yeah, sorry, there was the echoing before. Anyway, and just like having grown up in Eastern Kentucky trailer parks, I guarantee there's also a whole other group of people who could never afford the $200 fee to receive a card. So thanks for hearing me.
Thank you. Next up, we have Chet Watts.
Hi, folks. I know I only have 90 seconds, so I wrote this out so I don't ram. Apologies if it sounds a little robotic as I read. I just want to start off by saying that I am a patient as well as a cannabis industry professional in every facet of the industry from seed to sales. These opinions are representing myself and not the company that I work for. The opinions are from firsthand experience working in the industry. So first, I'd like to say that West Virginia holds the record for the slowest rollout of a medical cannabis program in the United States. It took us 4 years to come to an agreement on the program. In that time, nearly 20 citizens died from cancer or cancer-related complications. We were ranked third in the highest cancer rates in the country, and we were the most unhappy state in the U.S. While our legislation argued, we allowed our citizens to have horrific symptoms of this debilitating disease and prevented them from obtaining the medication that has been categorically shown to help. According to multiple peer-reviewed studies, stress and poverty do more to damage mental health in this state, though it will be easier to blame cannabis instead of systemic generational poverty and subpar mental health treatment availability. Now, we finally made progress in the state in the past year, and we have people who are able to finally have legal access to the medication that helps them. We have for West Virginia citizens, honest living, and serving a historically underserved population. The only thing that I can see that is a cause of allegorical and outdated evidence provided by a single person, single meeting. I've watched your last meeting multiple times, and it's me more times every time I watch it. It's full of tactics, outdated and statistics.
Mr. Watts,
correlation is not please. I would just like to say that please drop this THC cap proposal, allow West Virginians to make their medical decisions for themselves, allow physicians to prescribe what works best under their opinion. As always, Montani, Semper Mountaineers are always free. Medical cannabis in the state should remain the same. Thank you.
All right. Thank you. Next, we have Dr. Husted.
Hi there, Jason. Thanks everybody for hearing me out. So my role is I treat the sickest of the sick people in the hospital. Typically, it's either drug or kind of psychiatric conditions. And what I can tell you, because we were mentioning about psychosis being a concern, is I can definitely say with 100% certainty that we are seeing more and more issues when it comes to addiction from cannabis and people suffering from it. I'm getting, quite frankly, a little tired to talk to parents of kids that are using Delta 8 or cannabis products and they're struggling with it. And then I have the conversation that yes, cannabis can be causing this. Not always, but it often is. And they hear things like, no, I've never been told that. There was never any warning about it. We had no idea that high THC content could cause this. But it really is a thing. And I know we've had some comments about outdated information. I think, was it 2007, saying that all the data was from 2007. I know on multiple occasions we've heard this correlation between opioid overdose decreases with marijuana. And the reality is that came from a paper that was written in 2015. And that is since been superseded by data showing that there is no reduction in opioid overdoses from medical cannabis. So I know oftentimes if you read any kind of online forums or anything, and they'll constantly bring back this JAMA article.
Dr. Husted, I need you to finish up, please.
Yeah, but it's since been replaced. So again, examining the current evidence, there is no evidence that it lowers overdose death. So again, if we're going to stay up to date, I appreciate it. Thank you.
Thank you. Next up, Amanda Visinant.
Yes, hello. I'm speaking not only as somebody who deals with patients, I do patient advocacy on social media. First off, I want to say this isn't the program that we promised patients when we rolled this out. Patients got their cards based on a certain promise of a program. I echo what Rusty said. If we put this 10% THC cap in place, we're running all of our patients back to the black market and we're turning our patients back into criminals. I can say, as somebody who struggles with PTSD, I'm an Army vet, 10% THC cap isn't going to do anything for me. It's not going to touch most of the issues that I talk to patients about. And we are seeing that they are getting relief with the high THC percentages. Also, from the industry perspective, you're talking about having people who already don't get business deductions like regular businesses do. And we're going to ask them to take another big loss after they've invested millions into this state. And we already see we've got millions coming in from the medical cannabis program. I don't think our state wants to lose that money that we are bringing in.
Amanda, looks like you muted yourself.
Okay. That's pretty much all I wanted to put out today.
Thank you. Next up, Cody Peterson.
Hello, thank you, everyone on the panel. Thank you for your time. My name is Dr. Cody Peterson. I'm a pediatric pharmacist at Southern California Hospital, and I'm also a cannabis science expert with my master's degree in the topic. I'd like to talk a little bit about the THC limit as proposed at 10%. Look, I understand everyone's concerns around trying to protect patients, particularly those with young developing brains, and the issues raised by Dr. Stout are absolutely real and that we need to be very concerned. The endocannabinoid system is a masterful system that controls many important things in our body, and we should treat it with respect. However, my concern stems from the fact that this limit will not do anything to guide patients away from dangerous products, but rather force them to take dangerous products. Oh, by the way, I'm sorry. I'm supposed to say that I'm representing ASA, Americans for Safe Access. I told Debbie that I would do that. Anyway, this is going to be guardrails to patients to an illicit market. I can tell you as a practitioner in Southern California, I do see problems with cannabis. The most problematic products I see are from the black market, and setting THC limits, especially those THC limits well below the products that are currently available on the market and people are accustomed to, will create more demand, more incentive, and more profitability in the illicit market, and you will create more issues than you're intending to correct. In addition to that, I'd like to address the issue of addiction. Certainly, THC is addicting. It is mildly addicting compared to many substances that we freely accept adults to purchase, including cigarettes, which was mentioned by Dr. Stout as being extremely addicting. I would argue far more addicting and far more damaging than cannabis. We know 7 million people died just 2 years ago in one singular year around the globe from cigarettes, and 3 million from alcohol. Thank you so much for your time. Cannabis is medicine. Let's treat it respectfully, and let's treat it, regulate it like any other medicine. Thank you. My name is Dr. Cody Peterson.
Okay, folks, we're just going to take a brief pause on the public comments here. We will come back and take as long as necessary to get everyone. But I know we're coming up on 1:30. We've had a situation where board members have had to start to drop off before. So I want to talk about setting the next meeting real quick. And again, we will come back to public comment. So Glenda, can you go to the next slide, please? All right. So we have 2 action items revolving around Dr. Berry's recommendations. Do any board members wish to present any other action items, either for work groups or the next main MCAB meeting?
I would think the items we have will fill up the time we're going to have.
I agree.
And hey, Jason, I'm looking at your slide. On my end, I cannot do December 9th.
Okay. Real quick, jumping back.
I'm looking at both, and both of those I will not be able to do either.
Okay. Let me pull up my calendar real quick. So due to the holidays, my next suggestion would be January 5th. Any concerns with January 5th? Okay. Hearing none, we will set the next meeting for January 5th, again, noon to 1:30. Addressing virtual versus in-person, again, we had planned to have an in-person component to this meeting, but again, about a month and a half ago, COVID started to flare up again. We lost multiple members of the office, multiple members of DHHR. So at that point, I had a conversation with Dr. Amjad, and we felt it best to remove that in-person component. Unfortunately, that's not something we can predict. But if the members wish, we will again attempt to have that hybrid format for the next meeting.
I'd vote for the hybrid.
Me too.
Okay.
I also, before we move on, like it's not another action item, but reciprocity has been something that we've been discussing for a while. Are we planning to meet as a subcommittee to continue that discussion? Because I do think that that's also a very important discussion to have before the legislature meets.
Yep. So that is on the list of topics for policy and program, Rusty. However, we just have not got there yet.
Awesome. Thank you.
Yeah, we'll try to have a meeting between now and the next full board meeting, and we can definitely address reciprocity. It's on the list of things we need to address. And I mean, I wouldn't mind putting it on the full board meeting. I think practically on the time, I don't know how we're going to get through all of these, but if anyone thinks we should add it in, we certainly could try.
Okay.
We can just start with the policy work group and see what comes of that. I just want to make sure it's still, actively part of this discussion.
Yeah, it's definitely on the waiting list. Any other action items that members want to add?
So did we confirm we're going to attempt January 5th?
Yeah, January 5th.
1:30 in a hybrid format. We agreed?
Yes, if the pandemic allows.
Yep, understood.
Any other action items?
Oh, the only other comment I have, Jason, is thanks, Dr. Amjad, for your service, and we wish you luck in your next endeavor. So thank you.
Yeah, I second that.
Agreed.
All right. So I think we've concluded that official business. At this point, we'll jump back to public comment. And again, take as long as needed to get through all that. Glenn, but do you want to go back a slide, please? Just bear with me for a second, folks. So I think we're at Brad Heiler now. Brad Heiler. Okay. Moving on to Shanitha Lewis.
It's Shanitha.
Shanitha.
Yeah, it's a hard name to say, but I just want to say good afternoon. My name is Shanitha Marable Lewis. I am a medical cannabis expert. I have my master's degree in medical cannabis science and therapeutics. I am currently the West Virginia State Director for Veterans Initiative 22, and I am also on the alumni liaison for the Medical Cannabis Student Association. So first, as Dr. Cody Peterson said, who is my classmate and also a member of the Medical Cannabis Student Association, cannabis is medicine, which is evident by the fruition of the West Virginia Medical Cannabis Program. And it is common knowledge that the pharmaceutical medicine comes in many different forms, potencies, and strengths. So why should cannabis be treated any different? Patients with elevated pain levels, such as those who suffer from cancer, neuropathic pain, terminal illnesses, who suffer from neuropsychological conditions, such as those diagnosed with PTSD, like myself, have reported that low-dose products are ineffective for symptom relief. With all of that being said, many of the points that I was about to make have already been made, all except for one. In the paper presented by Dr. Stout, it says correlation is not causation. This is the opinion stated in the Shover et al. Paper presented at the MCAB work group meeting. It says in the conclusions, we are more cautious than others have been in drawing casual conclusions from ecological correlations and conclude that the observed association between these two phenomena, cannabis legalization and
Ms.
opioid
Lewis, I need
overdose
you to
rates,
finish up, please.
is likely spurious rather than a reflection of medical cannabis saving lives or killing people. Cannabis is medicine. Thank you.
Dr. Mazanet.
Hi, I'm a medical oncologist. And I'm the Chief Science Officer for Columbia Care, which is an MSO that operates in your state. I wanted to bring to everyone's attention that some of the published data that is equating high potency cannabis with psychosis uses black market cannabis. It's not talking about medical cannabis. And I would like to urge everyone on the board who reviews this material to do that seriously. The Lancet article that's often referred to actually is illicit market product. It's laced with a lot of other drugs. And when these kids and people come to the ER and are in a bad state, it can be multifactorial. So I think that it's very important that a medical cannabis eye be put on some of this, that, you know, when people come in, they have no other illicit drugs in their system and they have a card, that we need to know about that. But this is really, this psychosis that has been referred to as being due to high THC cannabis is in most cases multifactorial and illicit product. And I think that having a qualified standardized product with no cap is important to patients. So thank you very much.
Okay, next up we have Julie Sheeler. Julie? Okay, moving on to...
Yes. Oh, wait. I'm here. Can you hear me?
Go ahead. Yes.
Okay, I am a patient, and I have been using it since March. I have been diagnosed with both fibromyalgia and ankylosing spondylitis, two incredibly painful conditions. I have not had relief for the last 12 years that I've been suffering at all since I took and until I was able to do the medical marijuana. It has just been a life changer for me. I can only take one Celebrex a day because of my kidney and liver and all the other medications that I'm on. But the medical marijuana and certain people will always be addicts. They're going to be addicts to caffeine, you know, to everything. I think it's people have personalities that they're addicts, but I'm asking you, please do not drop the cap. I am not an addict. I use it for my health and surviving. Thank you very much.
John Allen. John Allen. All right, moving on. Eric Stamper.
How's everybody doing? Eric Stamper here, founder of Veterans Initiative 22. We've had a viable operational program in the state of Maryland that has been contributed to successful operations in other states. We value everything that the board over there is doing and appreciate full steam ahead as you march forward, putting together a viable program. Viable meaning not 10%. So we look forward to the future of West Virginia and supporting veterans, and thank you very much.
Tom Kane.
How you doing? Can you hear me okay?
Yes, sir. Go ahead.
Hi, how you doing? Yeah, I'm Tom Kane. I'm a 63-year-old disabled veteran. And there's a lot that I could say right now. I'm going to try to keep it short. If you reduce the percentages, you will kill the industry. People just can't afford it. And if you reduce the concentrates, you're making it uneconomical for folks, because all the concentrate does, it provides us a different way to take it. I don't like all the smoke inhalation. It's hard on my lungs. You know, I've got 8 of the 11 conditions they allow us. Prior to medical marijuana, I was taking probably 10 different kinds of medications from the Veterans Affairs. Some of them will make me pass out, and the side effects from them were worse than the pain and the PTSD symptoms and the hallucinations and all that other stuff and psychosis. Heck, marijuana helps me with mine. I'm just saying that y'all done a good thing here. You know, they've made it. I can look up a strain and it's going to tell me how it's going to make me feel. And it's accurate. If they cut it away, you're going to force people like me back to the street. And it's just like the lady before me said, you don't know what's in that stuff. You don't know, and you can't put this on the same field as pills. We all know, man. I was hooked on pills in the beginning.
Mr. Payne, I need you to finish up, please.
Okay, I'm just saying, think this through. You got some good people looking at it, and we appreciate it. But think about your patients out there. You do this, and you're putting us back on the street. But I appreciate the work.
And next up, we have Canisa Lopez. Canisa Lopez?
Yes, can you hear me?
Yes.
Good afternoon. Not only am I a patient, I am also a dispensary worker. I'm going to make this as quick and as sweet as possible. In October 2020, a car came through my job and struck me, which has now, I will suffer for the rest of my life. I am disabled. I have 3 kids. I have 4 grandchildren that I will never be able to pick up again. Not only have I noticed a difference in myself, but I also have in the people that I work with that we take care of. I have stomach ulcers, so I'm not able to take any kind of anti-inflammatories or pain meds. The breakthrough pain that comes through, most medicines, modern medicines don't help, but cannabis does. All of the different wonderful properties that are in that beautiful plant, for people who say that it causes psychosis and everything, my doctors, I don't hide it. People who are trying to use it as a medicine don't hide it. All of my doctors know that I use cannabis. My psychiatrist knows that I use it. It has helped me with my bipolar, my PTSD. I have came off of almost all of my medicines because of it. My social anxiety has lowered so much that I am able to go back into the workforce. It was because of being a patient at the dispensary that I am now an employee at, that I was able to be an employee again and be able to contribute to society again.
Ms. Lopez, I need you to finish, please.
I'll be quick. If we lower this down, I'm worried about not only myself being put back into my bed again, but what it'll do to our patients who are on the pain medicines who don't take it anymore, and what it might do to them. And will they OD if they go to start back on the dosage that they were already on? And thank you so much for your time, you guys. I appreciate you.
And next we have Brett. Brett?
Hi, I'm here. Can you hear me now?
Yes, sir.
Hi, my name is Brett. I am also a dispensary agent. I came here today to also share my public forum comments. I would like to talk about the angles of how prohibition doesn't work. We've got people on the streets that we're trying to advocate this stuff to and get them to come in and say, hey, quit taking this from your dealer. Come in here and, look at this cannabis. It's got THCV in it. It can help your tremors. It can help epilepsy. It can help diabetes. It can help all these different aspects that can really treat patients. But we're not focusing on the patients out there on the streets that's doing the levels of prohibition. We're ignoring them completely because we're focused on 10% caps. We're ignoring opioid patients, assigning away their opioids. They won't be able to even go back to the doctors for help. They say, hey, I don't know what you're going to do if we give you 10% at a cap, but here's this. They're not going to be able to go get their pills again. We're really screwing these people over. We need to start treating these patients like they're patients again and not like, as I've heard multiple times, not just once, like they're criminals. It's messed up. It's borderline terroristic. We keep intimidating these people out of the field when we need them more in the field. I love how well we're growing, but we could even be growing more. We should be trying to send this tax money to other states because what's going to happen in prohibition? They're going to go to California. They're going to go to Michigan. They're going to go to these other states they can get it from and just travel back with it because prohibition does not work. So if you want this tax money in the state, you want the state to be able to use it and prosper from it and help individuals, we need to start controlling and making the focus back on the patients again. That's all I got to say.
Okay. Next up, Nick Etten.
Hi, my name is Nick Etten. I'm the founder of the Veterans Cannabis Project. I have been working on this issue around the country, both at the state level as well as at the federal level for the past 10 years. I would like to state that capping THC limits would simply reduce the effectiveness of treatment and be incredibly detrimental for veterans and all patients in West Virginia who rely on this as treatment. But most critically, the proposed 10% THC cap will absolutely guaranteed drive veterans and patients to instead buy cheaper, unreliable, and dangerous cannabis products from the illicit and unregulated market. The proposed 10% guardrail, as it was called, is not a guardrail at all. It is actually an off-ramp into a pit of problems of bad health policy. I encourage the commission to get more data, dive into the research, listen to third-party experts, and understand what is actually happening in other states, not just speculating on it. Thank you.
Okay, Crystal.
Hi, can you hear me?
Yes.
I think it would be pretty good if we all started by understanding to be real and let's call a spade, that even though the opioid death rates have not plummeted, that's because THC tends to stay in our system a little bit longer. It's not that of alcohol. When you guys were speaking earlier about what is, how have psychiatric and medical been addressed? Well, I'd kind of like to share a personal experience regarding how my quality of life and psychiatric and medical issues have increased. 20, 30 years ago, I was diagnosed with PTSD. I was placed on Klonopin, 3 milligrams of it, for 20 years. That is a benzodiazepine a person shouldn't be on for more than 2 weeks. After I had talked to my doctor about that and told him my desire to receive medical cannabis, I have since learned that I have also been diagnosed with Crohn's. Now, in order for me to get any relief for the Crohn's and for the PTSD, I need at least an 80 to an 81%. But I will tell you that in culmination with that I have been successful with getting off of my Klonopin, and I am no longer a slave to that. And capping the the THC would just be unfathomable. If that's the case, then I would suggest that people who are currently doing this for a medical purpose with current levels should
Crystal, I need you to finish, please.
Be grandfathered into a different program. Thank you.
Okay. We've already heard from Eric Stamper. Next up, Owen Jeppesen.
Are you able to hear me?
Yes, sir.
I just like to make a statement to everyone out here to say that I'm very proud that we're standing together through this entire endeavor, and that we need to stay strong and make sure we push forward so we don't end up losing out on a really good thing. I'm an individual who suffers from Crohn's disease, and I was diagnosed at the age of 5, and nothing that I have taken in my entire life has helped me other than this wonderful, wonderful plant and medication that I have had. I've gone through treatments, sitting in a chair like a chemo patient and destroying my body just to have a glimpse of a normal life. My mother has twice survived breast cancer, and both of us have benefited off the wonderful effects of cannabis. Myself, I am working at a dispensary to aim and help people, and I think that if anyone's going to take into consideration, you need to look at all angles before you make a decision, because if you don't, you're going to make an irrational, poor decision that will never be reversed and will hurt people. That's all I have to say, and I thank you for your time.
Okay. Chris, I'm unsure if you want to speak or not. If you do, go ahead. Chris?
Yes, sir. Yes, sir. Can you hear me?
Yes.
Yes, sir. All I wanted to say was I appreciate Rusty being the spokesman representing me as a patient. Just wanted to give him kudos for his homework and his diligence. Thank you.
Chris, we've lost you there. Okay.
I'm finished, Jake.
Okay. We're going to keep moving on. Next up, John Allen.
Yes, sir. Can you hear me?
Yes.
Yes, I want to thank everyone for especially the experts and the advocacy of people. I'm a 65-year-old senior. I'm a diabetic. I'm a recovered addict. I used to do cocaine back when I was 20 years old, 25 years old. I have horrible neuropathy. I have had back surgery. I was on gabapentin. I was on tramadol. I was on trazodone. I'm taking none of those now. This helps me with my appetite, my diabetes, because I've lost a lot of weight, trying to maintain. So any cap would be detrimental to this procedure. And I've been very honest with my doctors about that I'm taking it. And of course, with the federal laws, you know, they can't prescribe you the gabapentin and the other Western medicine. So this is a holistic. I think it's beneficial. And thank you for the time.
All right, everyone. I believe we have covered everyone that wishes to speak in the chat. We'll give it just another second here. Again, if you wish to speak and provide your public comment, please enter just your name in the chat. All right. We're going to close that section out. Glenbo, you please advance the slide. We've already taken that. Folks, if you wish to provide a written comment to the board, please do so in email form to medcanwe@wv.gov by October 1st. That is always the best way to get a clear message to the board members. And as they mentioned during this meeting, we always send your comments to the board before each meeting. Right. I'm unsure how many board members we have left on here. We've concluded all the business for the board. Does a member wish to make a motion to close the meeting?
So, or second.
All right.
Second.
So I have a motion to close and a second. Again, just to simplify because of the format, do any members wish to vote nay on closing the meeting? All right. I'm going to say the meeting's closed for today. Thank you.
Thanks again, Dr. Amjad. Best of luck.